Hi, everyone, and welcome to today's webinar, Communication in the Age of COVID. I'm Stephanie Adler-Yuan. I'm Director of Training and Education here at the Schwartz Center for Compassionate Healthcare, and I'll be your moderator for today's session. We're so glad that you were able to join us today. This Compassion in Action webinar is a program of the Schwartz Center for Compassionate Healthcare. We're a Boston-based nonprofit organization established in 1995. Many of you, I hope, are familiar with our flagship program, the Schwartz Rounds, which is offered in hundreds of our member organizations around the world and provides caregivers from all healthcare professions with a forum for discussing the complex emotional experiences of caregiving. Okay, we're going to get started in a bit, but before we do, there are a few things we want to note about today's session. First of all, this special series of COVID-19 focused compassion and action webinars is supported by the Coveris Community Healthcare Foundation and also by a donation in memory of Julian and Eunice Cohen. We're so grateful for their support. Today's program is going to last about 60 minutes. We'll have a presentation for about the first 45 minutes, and then that will be followed by a 10 or 15-minute Q&A session and conversation with our Chief Medical Officer, Beth Lown. Although all of our attendees will be in listen-only mode and only on computer audio, we do encourage you to interact with our speakers using the questions pane on your GoToWebinar control panel. I also want to add that since I know so many of our colleagues are unable to join us live today, the program will be recorded and posted to our website by tomorrow morning. And we'll be posting the PDF of the presentation as well in case you're looking for that. Last thing, as you exit the webinar, we'll have a very brief survey, very brief, that we'd love for you to complete to capture your assessment of the program. We read every single comment. We appreciate your feedback so much. And now it's my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is our Chief Medical Officer here at the Schwartz Center and an Associate Professor of Medicine at Harvard Medical School. Welcome, Beth.
Thank you, Stephanie, and welcome to everybody listening. We're delighted you've been able to join us, and it is really a wonderful pleasure of mine to introduce my friend and longtime colleague, Dr. Tony Bach. Tony is a professor of medicine at the University of Washington in Seattle. He is co-director of the Cambia Palliative Care Center of Excellence, and he's also based at the Fred Hutchinson Cancer Research Center. Tony is triple boarded and certified in hospice and palliative medicine, medical oncology, and general internal medicine. He's also a co-founder of Vital Talk, which is a nonprofit social startup that he began. And this Vital Talk has trained more than 650 faculty across the globe in the US, Asia, Australasia, and Europe. So we're really excited to have you join us today. Tony, thanks so very much. I'm going to turn this over to you.
Thank you, Beth. It's really a pleasure to be here. You know what, I just tried, can you hit this? I just tried the slide thing and it just didn't seem like it. Oh, maybe I need to, there we go, okay. So as Beth mentioned, I'm in Seattle. And right now, we look like we are a little past our first peak. I mean, I don't know how many peaks we're going to have, but it seems like we're a little past our first peak. I know that you may be calling from any part of the country, and that different parts of the country are in different places. And so I just want to mention that I think we're at a complicated time in the evolution of the pandemic right now. And as we evolve through it, and our different regions evolve through it, I think we are all going through this kind of dislocation, kind of this re-equilibration, this kind of figuring out what the new normal is going to be. And I think one of the really complicated things is that we know that there is going to be a new normal, but we don't know what it is going to be. Our own institution just had our first virtual Schwartz rounds last week with like 300 people on a Zoom call. And one of the things that really stood out was the number of clinicians who said, basically, I can't do what I was trained to do. And there is this real sense of loss and inadequacy and the sense that they're not quite doing the right thing. And I think that makes it more important for us as the community that cares about communication, that cares about clinicians, that cares about compassion. It makes it more important for us to articulate those values and talk about how they can happen, even under the constraints of PPE, social distancing, all this other stuff. So I wanted to mention that I'm going to be coming back again and again to three kinds of things. One is that in these times when everything is disrupted, it's more important than ever for us to relocate the principles of what we are doing. And I will be talking about some principles of communication. The second thing is that we have to reinvent new ways into the kinds of interactions, the kind of conversations, the kind of physical proximity that allow us to do the work that we are doing. And the third thing is that I think it's really important for all of us in this webinar, even if one of our main issues is compassion, and I know that's the reason you're here today, it's really important to reach beyond your silo, because in many ways we are reinventing right now what medicine is going to look like 20 years from now. You know, if I look at the latest projections from these are from the Institute of Health Metrics and Evaluation at the University of Washington, there are 134,000 deaths projected by August the 4th. I mean, it's a staggering number. It's an unprecedented number, and it's like the equivalent of almost the equivalent of a 9/11 every day, right? None of us have experienced anything like this before, and I think that's one of the reasons it feels really disruptive and dislocating, is because it feels like nothing we've ever experienced before. Before I get into, you know, some of the COVID specific stuff, because I know this group is really interested in clinician-patient relationships in general, you know, that's what got the Schwartz Center started. I just wanted to say a word about what the world was like right before COVID began, because it turns out I was doing some focus groups with consumers about serious illness care and how they saw it, and they were quite revealing and honestly sobering and kind of eye-peeling. So I'm doing some work to think about how palliative care, hospice care, advanced care planning could be messaged to the general public. And so we did a series of consumer focus groups about those issues and how the public saw them. And the public had a number, these people, the consumers, these were all people who had family members or friends who had lived with a serious illness, but did not have a serious illness themselves. They had some pretty sobering preconceptions that actually took my breath away. The first preconception was about advanced care planning. You know, we think of advanced care planning as, you know, talk about your preferences, whatever they may be. Actually, these consumers, to a person, thought that advanced care planning meant agreeing to a do not resuscitate order, right? Advanced care planning is agreeing to a do not resuscitate order. Wow, like I was super, like, I was shocked, to be honest. And it's kind of the legacy of some of the public messaging that has gone before us. The second default story that they held was that talking to a doctor about a serious illness was going to be the doctor coming in and telling them what they had to do, whether they liked it or not. I mean, actually, they were a little confused by the idea of talking about goals and preferences, because they were so used to clinical encounters where the doctor just comes and tells them what to do. So their default story is getting a lecture. The third consumer focus group finding that I thought was really sobering was what it's like to be a family member when someone has a real serious illness. And the default story of being a family member is you're going to be called to a family conference where some doctor is going to tell you that you have to make a painful decision to pull the plug on somebody that you love. That's their default story about family meetings and dying of a serious illness in the hospital. The reason I mention these, and these are like, honestly, they're way worse than I expected. That we actually had a messaging question to them about care, and the idea that, you know, a clinician would say that it's a privilege to care for you. And these focus group participants, who were in 3 different locations across the country, like 80% of them said, that sounds like advertising. One of them said, like, is that for the caregivers or is that for us? Another one of them said, that is just way too saccharine. Another one said, it's not a privilege. I'm paying you to do this. Like, what that told me was that there is this simmering undercurrent of mistrust in what is happening between clinicians and patients now. And I think it's an important kind of background for us to think about as we go into what is happening with COVID. So from that kind of simmering mistrust, we move into this space where there's kind of this virus that is unprecedented. It's going around. It seems in some ways uncontrollable. It seems in many ways beyond the reach of the medical system. And I think that is one of the reasons that there is so much agitation about what is happening between doctors and patients. And there has been so much of a focus on what would happen if the medical system runs out of something, because basically the public, I think, has a very significant amount of mistrust that if resources or something critical is limited, that they will not be able to get their share. I can't even tell you, and I did some interviews with people, consumers related to COVID, and one of the things they said was, well, why did all the celebrities and basketball players get tested first? Like, what is that all about? And of course, you know, there is no answer to that. Okay, I'm trying to move. Okay, so what happened was, I'm in Seattle. We had the first case in the country at the beginning of March. In the middle of March, I decided that we were going to need to respond to this in a new way about communication. And so I wrote and published this little guide to COVID-Ready Communication Skills on the web. The first edition went up the 15th of March. Over the next, 3 weeks, it kind of went all over the place, and it was translated by volunteer clinicians into 16 languages. And so now you can get the whole thing in our website, vitaltalk.org, and it's available there in English and all the 16 languages in different ways. And what we tried to do was use the principles that we know work for communicating better with patients who have a serious illness and translate them into language that is specifically related to COVID. We also put all the stuff in the playbook into the Vital Talk Tips app, which is free on iOS and Android. We are distributing the PDF for free, with the idea that basically everybody needs to use something like this. And you can see here the sections about the communication guide range from how do you talk to patients about screening for COVID? How do you talk to patients about what their preferences are if they need basically advanced care planning for COVID? We actually did not call it advanced care planning in the playbook because of this previous experience that I told you about, that advanced care planning means agreeing to a DNR. We have a couple of sections in the playbook that are specifically for regions that are in surge or crisis standards of care. And at the time the playbook was first published, there was a great deal of confusion in the clinician world about what it meant to operate under crisis standards of care. Now, I think a month later, the reality has changed, right? We have not moved to crisis standards of care anywhere in the country, despite all the worries about it. I mean, there have been individual hospitals that have been short of ventilators, but there is no region that has declared crisis standards of care. And so I think those sections of the playbook and this whole discussion about rationing are a little bit less relevant right this second, even though I think many clinicians are really worried about it. So that said, crisis standards of care are not what you should be training your fellow clinicians about now. It's really about how do you deal with what's happening now in the social distancing and the unique kinds of things that come up. We summarized some of the principles that we are highlighting in this article in the Annals of Internal Medicine, which is free. And the principles are things that you all know, and they are the following. The first principle is that emotion is more important than information. Like, for those of you who are well acquainted with the communication skills work that we and others do, this will be no surprise. But for those of you who haven't, I think it's worth remembering that emotion is not an additive. It's not an impediment. It's not an epiphenomenon. Emotion is the way that we take in really important information. When you hear something and it sets you off, the emotion that happens is faster than rational thinking. And once it starts, once a wave of emotion starts, it is unstoppable. You cannot intentionally stop it. I mean, you can try and suppress it, like most clinicians are quite good at suppressing their emotions, but it turns out physiologically, when you try and suppress an emotion, actually it lasts longer and it is more bothersome, and actually it detracts from your bandwidth to pay attention to a patient. So in fact, what I learned as a young medical student about denying and suppressing emotions, it turns out that was totally dysfunctional, unconstructive advice, and yet so the first principle, emotion is more important than information. The second principle is that when you do give information, you need to give it in small chunks that start with a headline. So if you are a clinician who's giving news about COVID, for example, or news about respiratory failure, think of it like a newspaper story. What's the headline? What's the summary so people know where you're going? The default tendency of clinicians, and we are trained to do this in medical school, is we tell our story of the illness. Here was the first symptom the patient reported. Here's the first diagnostic test that got done. Here was the problem we had. Here was the next diagnostic test, right? And you go through all these things, and then the patient gets lost, and then by the time you get to the news, they're all jumbled. The way around that is to start with a headline. Here's what's happening. The COVID test was positive. And you can backtrack from there and add information from there. But really, the first thing is you're going to have to see what the patient's response is and deal with that. And after that, then you can figure out how much detail people need, where you need to go with them. But don't underestimate the importance of a headline, and don't underestimate the complexity of boiling down an enormous amount of medical work that you've been doing to a headline that somebody can understand if they are super stressed. We always talk about high school education, but the reality is, many of the patients that we are in front of are so stressed that what they actually can take in is more like at the 6th grade reading level. And I don't mean that as talking down to anyone. I mean, it happens to the most educated person. It happens to, computer science professors that I see here from the University of Washington. So the second principle, again, is when you need to give information, give it in small chunks that start with a headline. The third principle is about the idea that patient values should guide the selection of medical treatments and should guide the construction of a medically feasible care plan. This principle is the one that is suspended under crisis standards of care, right? Our current triage standards, although they're a patchwork across the US, they generally take a kind of a utilitarian approach, the most benefit for the most people. And under those circumstances, triage committees make decisions that aren't about patient values. But remember, we are not in crisis standards now. We actually never have been. And despite the media hype about them, because it was a clickbait issue, honestly, and despite the clinician uneasiness with that, because honestly, as a clinician, it feels horrible to ration, we haven't reached crisis standards of care anywhere. Now that isn't true in every other country. Clearly Italy was in a crisis mode for quite some time, and in some areas still is. But currently here we are not. And so when everyone starts to jump to this issue of what about rationing, I think it's really important to ground everybody back into reality, to say, actually, that is not the situation now. It's part of our tendency as we think ahead to wonder about the worst possible scenario, to catastrophize. And part of that is important, proactive thinking that is useful in disaster planning. But the other part, there's another part of it that's actually kind of reactive, worrying, and ruminating that goes on and on and on, that we actually have to learn to regulate. So in thinking about communication skills, and this is in many ways one of the fundamental things that clinicians do that makes compassion possible, right? There is no single thing you say that is compassion, but compassion emerges when a number of things are in place, and one of them is communication. One of the tasks, the new kinds of communication tasks that came up that we highlighted in our playbook, is how do you say goodbye? How does a family member say goodbye when they can't be at the bedside, and when a clinician can't do much more than hold the phone up to the patient's face? So we designed a way to do that, and it's summarized by an acronym called LOVE, L-O-V-E, and here are the steps. Stanford Medicine adapted this very slightly and put out this nice handout, and so that's what I'm showing you. And the first step is lead the way forward. So what that means by leading is that this is such an unfamiliar situation that you are going to have to take the patient by the hand, metaphorically, and explain who you are, what's going to happen, how you're going to do this, what it looks like on your end. And what you're doing as a clinician there is, in the world of virtual interactions, you have to paint a picture on the patient end of things so that the person, the family member who's listening in or watching, can actually visualize in their heads what the interaction would be like if they were sitting right in front of the patient, right? So you have to say, I'm one of the professionals on the team. For most people, a tough situation, like here's what we're doing, right? And then you set up the idea of the conversation, right? So the important setup here is that you need to focus people on what is possible and what you are able to do. Because if you start with what isn't possible, that is the frame on the conversation that you will be setting, that it will be very hard to break out of later. One of the things that we at Vital Talk have learned after now years of teaching people to do goals of care conversations is that the impulse to talk about what you can't do first is so strong. Most clinicians, when we get into our interactive trainings with them, they don't even realize that they do that until they see themselves, until they hear themselves do it in a controlled, educational situation. So you have to start with what you are going to do, and in the same way here, you have to start with what is important. And the O is to offer things that matter to most people. So here are here's some things to say. And you'll recognize these as Ira Byock's 5 things to say at the end of life. Forgive me, I forgive you, thank you, I love you, goodbye. And you are offering those things as a way to give words to a situation that honestly nobody wants to find themselves in, and that most people feel really tongue-tied about. So actually, this is where offering words to get things started can be really useful. The third thing is to validate what the person wants to say. Okay, I'm going to say goodbye, and the clinician can reinforce that by saying, I think that's a beautiful thing to say. If my daughter said that to me, I would feel so valued. I think they can hear you even if they can't talk back. Go ahead, right? So in a way, this is quite a long preparation. And why this is so important is that's what virtual encounter takes, because nobody has experience, right? Then the last thing is expect the emotion and work with it. I think what happens in these situations and what we have seen happen here in Seattle and I've heard around the country is that everyone, as the conversation starts and everyone is taken a little aback by how real it is. They think, oh my God, this is just, they start thinking, oh, it's going to be a phone call. It's going to be a little remote. It's going to be a little impersonal. But you will see rapidly that a tremendous amount can happen over the phone, even without a tablet or in Zoom. And that the clinicians I have spoken to, around the country, they say, wow, I felt like I had a different role here. I was a conduit in this conversation, not just a bystander. I had a role that made things possible in a different way that I ever imagined. And so really there's emotion both for the clinicians and for the family members. Very often the family members are really struck by the gravity of the moment. They never expected it to be like that. And there's something quite unfamiliar about doing this when you're not in front of someone face to face. And I think the irony of these virtual encounters is that they are teaching us how important face to face really is and teaching us something about what is so profound about being in someone's presence. And so for all of us, clinicians and lay people alike, the idea of personal presence, I think, is being reformulated as we speak by these kinds of encounters. We had a little video to show, and we're not going to show it because of the bandwidth issues, but we will send you a link to a video that I made with an actor on Zoom to demonstrate exactly what this would be like. We actually filmed the video on Zoom, and we imagined how it would be to have this kind of conversation. And you can see in 3 minutes the trajectory of what this sort of thing could be like. And since we released this video, people have been having these conversations all over the world. And it really goes to show how, tapping into one of the most important things that we do as clinicians has tremendous staying power, even when everyone is a little overwhelmed, even when the clinicians are like, oh my God, more PPE, even when they're like, oh my God, I can't even go into this room, even when they are worried that they are at risk of being infected. There is something incredibly powerful about the relational work that we do as clinicians when we are with people who have a serious illness. I'm going to move to another topic now, and this one is a little bit more technical, and I'm not going to go through it in so much detail. This is a acronym for doing the kind of advanced care planning, proactive planning that everyone is doing in contingency situations. They are talking to patients about, if you had COVID, if it got really bad, would you really want to come into the hospital? Would you really want to go into the ICU and get intubated? Because for some groups of patients, the chances of surviving are extremely, extremely low. So the acronym that we developed for this is called CALMER. The C is for check-in. How are you doing with all this? A is asking about COVID. Go right to the main point. What have you been thinking about COVID in your situation? Because it's, all the media is all COVID all the time. L is laying out the issues, including anything you want us to know if your COVID gets really bad. M is motivating them to choose a proxy and talk about what matters. So, if you look at all the advanced care planning literature, it's really converged on two important things. People should choose a proxy and they should talk about what is important for them in their healthcare. E, again, expect emotion and acknowledge it, because when you acknowledge people's emotions, it allows them to process them in the moment. And R is record the discussion, because anything you record, even brief, will help your colleagues who are seeing the patient next. So the idea is, again, this is a simple way to have a kind of COVID as a starter preferences in a healthcare setting. And it's a way to give clinicians a new way into things that they're actually quite familiar with. Many clinicians who are doing this now have done a version of this in the non-COVID era. And now I think the issue is how do you approach it when COVID is like the gigantic elephant that's blocking everything else from your view. So there are a number of other acronyms and tools in the playbook, as well as answers for many specific current questions. I would be happy to answer more specific questions if there are other situations that you would like to ask about. So please just type your questions into the question box, and Beth will read them to me, and we will have some discussion about that in a bit. But what you can see here is that one of the ways you can get if you are a leader or somebody who is in charge of, what clinicians should know and how to get them interested, use COVID as a way to make the work of compassion seem urgent in the current environment, right? Like, we can use this pandemic as an opportunity to highlight all the things that we really should be doing. Okay, I'm trying to go to the next slide here. There's this little lag when every time I push this thing, and it's kind of, there we go. The last thing I want to mention in terms of my formal comments are that I think for all of you, because I think if you're on this webinar, you are leading in some way, right? A formal or informal way in your healthcare institution. And I think one of the really important things to bear in mind is that, everyone expended a tremendous amount of energy getting ready for the surge. Now that we may be at the peak or a little bit past the peak, everybody's kind of thinking, okay, what now? And I think what that does is it opens this window for everyone to think about what are they feeling and start to notice how much psychological stuff is happening. Jennifer Senior here talked about the psychological trauma that awaits doctors and nurses. And I don't know if I would go so far as trauma, although it is very clear that exposure to this kind of death increases your risk of post-traumatic stress disorder. That there are many clinicians, nurses, and doctors both who are being more exposed to death than they ever have before, even if they worked in ICUs. And that the number is kind of an unprecedented thing. And so I think the kind of moral distress or just distress that happens is something that we are all going to be grappling with. And I am really getting prepared for a kind of an aftermath of grief. That is one of the things that we addressed in the Schwartz Center rounds that we had at our institution just last week. And I think it's clear that it's going to be an ongoing threat. You may know that one of the important principles here is that in-depth critical incident debriefing in the moment, the way that you may have done this for errors, for example, that actually has been tested in first responders in other disaster situations, and it had negative consequences. So I think you should be very careful to know that critical incident debriefing, the way that is usually done in the midst of a trauma, is not the thing to do. It turns out that having people go through exactly the horrible thing that they just experienced when they are exhausted, when their psychological defenses are down, when they don't have a safe space for themselves, it turns out that may just re-traumatize them. And so I think we need to be really careful as a community not to set that up as the standard for how we support and take care of each other. Before you can process this kind of huge issue, you need to be, you need to have eaten, you need to have slept, you need to be in a safe space, you need to have somebody who you feel confident is really going to listen to you so that you have that degree of psychological safety. Unless that you can create that in a place, unless your clinician is ready for that, you're not doing a favor by asking them to dig deep into the most difficult thing. And so I want to be really clear that we as a community have to figure out how we are going to help each other work through the aftermath of this pandemic. And it's going to be different than what we've ever seen before. And the reality is there isn't a lot of data to guide us. There is no first responder gold standard psychological intervention that prevents PTSD. I wish I could say there was one, but it just doesn't exist. in this environment, a friend of mine in New York asked me, like, what am I going to do for my clinicians who don't have time to take a break? They're doing 10 Zoom calls back to back, like all day long, and they're all talking to families who died. And I said, would they have 10 minutes to listen to a podcast on their way home? So this podcast that I started called Decompress is designed for 10 minutes between the time a clinician leaves work and before they get home. So I'm not asking them to use new time. I'm not asking them to take time out of the time they need at home. But it is an intentional way of ending the day by saying, okay, I'm done with my work. I'm going to power down, set myself for an evening of renewal and reboot so that I'll be ready to come back tomorrow. I think this is an interim step before we do the big work of dealing with the aftermath, but it's a measured step that helps give clinicians some emotional self-regulation skills, some attention balancing skills, and some ways to calm themselves that take them out of their usual habitual impulse to think their way out of a situation, to continue to problem solve long after the problem is gone, to go around and around with the things that they should have done instead of finding a way to experience the emotion. So I am going to see what kinds of questions you all might have. I just want to reiterate. So the things that I'm talking about that I think will serve you in your institution, wherever you are in the pandemic, and serve us as a community are these three things again: relocate the principles of communication and self-care, reinvent new ways in that take advantage of the urgency that COVID has created, and reach beyond your silo in thinking that these are not just individual problems. They actually involve the system. They're not just system problems. They involve teams and individuals. They're not just team problems. Teams need individuals that have taken care of themselves. And so I think there is a way in which this is forcing us to, in a good way, look at the connections between these things and stop thinking about problems clinicians are having now, like burnout, et cetera, as just system issues or just individual issues. I am very aware, that we are shaping now what medical care will look like in 10 years. We're shaping it right now. It's not that all the things that we're doing now that seem like workarounds or seem like innovations, what's going to happen is that some of them are going to stick and they're going to become a standard part of our repertoire. And so we need to be careful in thinking about how we innovate, about what we are doing now and what we want to stick. Because if I look at what happened after the AIDS epidemic, there were some incredible legacies of that. Like I'm a palliative care specialist now. That specialty probably wouldn't have existed without the AIDS epidemic, right? FDA accelerated approval for drugs like the exact mechanism that is being used for remdesivir now, that did not exist before the AIDS epidemic, right? There are a number of things that legacies of that epidemic that are still with us in incredibly powerful ways. And I think what we need to do as a community is be on the lookout for those opportunities, because that is how we will emerge from this pandemic in a stronger, better, more robust kind of way. I think that is the end of my slides, Beth.
Thank you so much. Thank you, Tony. This is really so helpful. So thank you for the presentation, Tony. I can feed some of these questions over to you. Yeah, so there are several interesting questions. One of the first that came in, and I'll just read it. What about balancing the risk to staff with intubation versus the potential benefit to the patient? We had made some patients DNR in whom intubation was felt to be medically futile against family wishes because of this rationale. I wonder if you might comment on that.
Oh, yeah, you mean the idea that some patients were made, that a futility rationale was used to make patients do not resuscitate? Is that what you're, is that what
That's
you're?
what the question suggests,
Yeah,
yeah.
yeah. Well, so, here, I actually think in the worry about shortages and rationing and futile care, I do think there has been an impulse to make more unilateral and more paternalistic decisions about intubation and about ICU care. And that is where I think if we are not in crisis standards of care, I think we as a community have to be really careful about that. I mean, I saw an article today in Stat News about a lung cancer patient, metastatic lung cancer patient in Boston, your hometown, that actually reversed her DNR because she is so worried that care will be rationed inappropriately to her if she got COVID. And I think what that feeds into when we act in those paternalistic ways outside of crisis standards of care, I think it feeds into the mistrust that that already exists in the system. So I think
Yeah.
we have to be super careful.
Yeah, I agree. I wonder if you can comment a little bit more about this mistrust. I mean, there is quite a lot of discussion about that. And there was also a recent survey indicating that people really are trusting what their healthcare professionals are saying in the midst of this crisis. So it's an interesting sort of paradox. Do you have any thoughts about that and what we might be able to do now and in the future to restore that sense of trust, Tony?
Yeah, it's a really good question. And I think some of the differing results come from different ways of collecting data. Like I think when patients fill out surveys, what you get from them is quite different from when they are having an open-ended conversation in a focus group. And so I do think that there is for the public right now kind of this mixed picture of trust and mistrust. And the reason I highlighted the mistrust is because I think clinicians overlook it. What we did a parallel set of clinician focus groups, clinicians who were involved in serious illness, and the clinicians didn't even seem to have the mistrust on their radar screen. They didn't have cost on their radar screen. Literally, it did not come up in the focus groups. And yet the patients were really super concerned about both things. And so I feel like that part of the thing that we need to address is figuring out where those disconnections and blind spots are for clinicians so that we can face those issues more squarely. And I think one of the good things about this COVID thing is that it is putting, for example, these crisis standards of care under public scrutiny in a way they never have been, right? The disability people in Washington state sued the government about crisis standards of care because they felt they were discriminatory. And, actually, I think that is an important kind of public discussion to have because I'm not totally sure if that's the right thing to do with these crisis standards of care either. But in the middle of a crisis, like that's not the time when we can really have this important public discussion.
So a topic
I
for a
think
little
it
bit
points
later,
to
yeah.
a kind of we're going to do later. Yeah, absolutely. So what's next?
So let me ask this question next. This is really important for parents of children with underlying medical conditions, cancer, cystic fibrosis, and the like. What are your recommendations for supporting them in their fears about COVID and also the isolation that these families are experiencing?
Yeah. So I think for children, and of course, there are age-dependent aspects of this. I think the question is what creates psychological safety for that child, and what are the things that can still be done, even in all these different circumstances, right? Because all the people that child interacts with are part of kind of the system of psychological safety that has been created. And how can that circle of psychological safety still be drawn upon and reinforced, so that despite the fact that you can't visit in person, despite the fact that you might have to be dressed up or whatever, how can we ensure that those children know that we're still here, that we're still thinking about them, that there's still many things that can be done, that we're still going to take care of them? And so I think it's up to us to figure out how to be creative about what makes psychological connection and safety when we can't depend on the things that we used to take for granted.
Right, exactly.
Yeah.
There's many more questions coming in, Tony. I'm going to read you some more of these. There are a couple of questions about what can we do right now to support healthcare workers and staff in the midst of the crisis. So many are so busy, it's hard to know what's going to actually help them. You know, they're going to be balancing their desire to get home if they are going home at all.
Yes, yes. So I have two thoughts about that. So for what can we do for clinicians now is, I think what we should be doing is we should be modeling ways that people work in ways that allow them to take little mini breaks, to batch their work, to not work without a break. Like that actually just isn't a healthy way for anybody to work. And even in the midst of this, I think we are going to have to create ways clinicians to take little mental breaks, and for them to wind down at the end of the day with no expectation that they are going to be going home, doing more hours of work on the computer, calling back to check on patients. And we clinicians are going to have to build networks of trust with each other to make that happen. And I think we all need to realize that the old way of you know, the heroic doctor who never takes a break, who never stops, who's always on, that actually is a recipe for disaster right now. And it's not a healthy thing. And I think we need our leaders to model that and walk the walk about that. Yes.
I agree. It's absolutely true. And there are other, yeah, I agree with what you said about critical incident stress debriefing and the research that's been shown about that. So it's good to keep that in mind. There are, go ahead. I was just going to say, you know, for people who do Schwartz rounds, who are members, we have put out some guidance because people are doing virtual Schwartz rounds, and we worked hard with the National Center for PTSD to create a trauma-informed way of doing virtual Schwartz rounds that uses stress first aid models to guide that kind of, you know, gathering. But, you know, I think there's nothing known really, literally about, you know, what will be really effective and helpful. So it's very difficult right now. Let me pose another one of these questions to you. One person asked about the place for religious and spiritual values and practices and how these can be worked into discussions, not just with patients and families, but with clinicians. Very interesting question.
Yeah, so you know, I think it's really interesting. I have been doing some work in the kind of this new field of psychedelic assisted psychotherapy, and I am not saying that psychedelics are the answer to this, but I think what they are showing us is that there is a kind of a bedrock kind of experience for humans that is often called spiritual, that has tremendous importance to us all, and I think how that comes into our day-to-day work is something that we all have, each of us has to figure out how to hold in the middle of this. You know, I've met Brother David Steindl-Rast, you know, the gratefulness guy, just a few months ago, right before the pandemic, one of my last trips before the travel bans. And one of the things I asked him what clinicians should be thinking about, and what he emphasized was the incorruptibility of the human spirit. And I was so interested in that word, incorruptibility, because I think it suggests that there is something within each of us that is kind of sacrosanct and that actually is always present. And understanding how to nurture a sense of that, actually, I think is something that I have really learned in my own spiritual practice. And maybe this is something that will reveal more the need for that for all of us. It turned out my own clinical practice led me to a kind of mindfulness practice, and now I've been a long-term Zen person for quite a while. I'm not saying that that is the path for everyone, but it certainly came out that recognition that spirituality had a particular place in how we all bring ourselves to patients. That actually did come directly out of my work with patients.
And that really is so individual to each person, where they find that. Yeah.
It is, and so I think what we have to emphasize is the importance of that personal exploration, to sort of look for that and kind of realize that there is a process out there and that it is a very individual thing for all of us.
Mm-hmm. Yes, yes.
So I see one of the other questions, I think Elizabeth Copeland asked about the catastrophizing and the psychological trauma. So what I just wanted to clarify that. What I was trying to say was that one of the common coping mechanisms, or one of the common reactions that clinicians have to bad situations, is to catastrophize. And so that is a common reactive kind of response that isn't very that isn't constructive, actually isn't protective, isn't adaptive. Those non-constructive coping responses, those actually set us up for more psychological trauma later, because we actually end up traumatizing ourselves. It's not just the event that traumatizes us, it's actually how we treat ourselves that adds to the trauma. And so I think Elizabeth's question was, I'm hoping that I tried to clarify that. She also asked, how can therapy professionals help providers as they come out of the current trauma? Well, I think that's the issue that you highlighted, Beth, that there's no simple answer to. And yet, what I would say is that if you look at the experiences of first responders, and there's not a lot of data about this, but first responders and combat veterans, it's really clear that speaking your experience with a trusted person or in a group of trusted people, that has an incredibly powerful effect. And one of the things that is very clear from the experiences of combat veterans who have returned back to home is that the sense they have of still having a group where they belong, a group where they can speak their truth, that actually is correlated with psychological sequelae. And I think we need to create the same kind of thing for clinicians. And some of it may be individual, or some of it may be in groups, but I think that the thing that we can create is making sure that those kinds of places exist and are available.
Yes, and we actually have heard that too, Tony. It's so interesting that many people have commented that if they're going to receive support, they want to receive support from people who have walked their walk, who know what their experience is like. Yes. Who have sort of lived and walked in their shoes, so to speak. So I think that that's an important point. We want to bridge silos, and at the same time, we want to make sure that people have the kind of support that they can use. So it's a complex issue.
It's so interesting because, I think one of the things that I have seen is that the bridging the silo work is different than your own cultivating yourself work. And so we have to not confuse them. You can't, you have been seriously, if you've had some serious psychological stuff that's happened that you need to work your way out of, you need to find a safe space. This is not the time to push yourself to meet new people and be in a new group and try and incorporate all that stuff. You need to focus on psychological safety first, because that's the precondition for all that kind of work, right? So you're right to ask me to clarify that.
Yeah, that's so interesting. So I do want to ask, I think we have time for maybe one more question or so, and that's to comment on telehealth, because I don't think it's going to go away.
No, and it shouldn't.
So I think it is here to stay. So can you, I know we value in-person connection, and yet, there's value to connecting, period. So what are your thoughts about where this is going and how to make it work for us?
Yeah. So, you know what? I think what we're learning, I feel like we are going to learn something. We're in the middle of learning a bunch of things about what telehealth is good for and what telehealth isn't good for. I hope it stays with us because I think there are many ways in which it allows people easier access to clinicians for, some things. I also think that we all have to remember that even when you're on a telehealth visit with a patient, that you are actually receiving a far reduced stream of data than you would get than when you were with a patient in real life. And so you actually have to move a little bit more slowly when you are in like tender psychological territory because you don't have as many clues. And you have to actually keep in mind that you are operating like with one hand and one foot instead of, everything, all your functions. So, and I think it's important for us to help patients understand where the limitations are and why sometimes it's important to go more slowly on telehealth. I have to say now, having done loads of telehealth visits, it's almost a different kind of work, right? I mean, there is this kind of tiredness and fatigue that you feel after the end of a long telehealth day that is different than when you are with people in person. And, there's some good physiological reasons for that. There is something neurochemically that happens when you are in front of a person and you look right into their eyes and they respond to you in real time, right? Like there is all kinds of stuff happening in your brain that actually doesn't happen when you're on Zoom. And so I think we as clinicians have to remember and figure out how to continue those kinds of connections that are face-to-face, are physiologic, are important, and we're all going to have to learn how much we can do when we can't do that.
So to be aware of its advantages and its limitations.
Yeah, I mean, it's not going to be a complete substitute, and I don't think we should talk about it like that. And yet, it's good for a lot of things.
Yeah, for sure. So I'm afraid there are many more questions, but we are going to have to wrap up the webinar. I'm so pleased to see that people were engaged and are putting their questions out there. But I want to thank you, Tony, for sharing all of your experience, your wisdom, your advice, what you found and learned, your research. We really appreciate your joining us today, and I want to thank everybody who has attended the webinar. And I'm going to turn this back over to Stephanie to close us out.
Thank you.
Yeah, thank you, Dr. Back, and thank you so much, Beth. So many great questions. I wish we had another hour, but we do hope you enjoyed your time with us today. We have a great slate of speakers still coming. Next Tuesday, we'll have Dr. Sunita Puri, the author of That Good Night, and she's a palliative care physician at USC. And it should be great. She's going to talk about how we can process grief through stories, which is right up my personal alley. So I'm looking forward to that. Last but not least, we want to share news of our 2020 Compassion in Action Conference, which will be offered as a virtual event this year, sure to be as fun as our live event. And we will have an outstanding series of workshops, panels, lots of speakers, and we hope you'll join us. We do have scholarships for that available, so take a look at our website if you'd like more information. And until then, we know everyone's busy, but we're so grateful that you were here today. We'd love if you would take a minute to fill out our survey and share your feedback as you leave the webinar. We will be sending a link with the recording tomorrow, so keep an eye out for that. Feel free to share it. And if you'd like to learn more about the Schwartz Center, there's our website and social media. And again, thanks for joining us. Be well, and we're so grateful for all that you do. Take care.